Hi everyone, today I am giving you information on the topic hypermetropia or hyperopia. This is the part 2. So let's see what is the basic. In case of hypermetropia, when the parallel rays of light coming from infinity, they will focus at the point which is behind the retina. If you see here, the parallel rays of light are coming from infinity and they will focus at the point which is behind the retina. Okay, so this condition is known as hypermetropia. Whereas in case of normal condition, parallel rays of light coming from infinity are focused at the point which is on the retina. So we will use the plus lenses here to focus the image on the retina in case of hyperopic patients, okay, to make it normal. So let's move to the next one is the clinical picture. Clinical picture includes symptom as well as signs. So let's see what are the symptoms. Four types of symptoms are there. First one is asymptomatic, next one asthenopic symptoms, third one defective vision with asthenopic symptoms, fourth one is defective vision only. So let's see what are the asymptomatic symptoms. Asymptomatic means without any kind of symptom. In this case, a small amount of refractive error in young patient is usually corrected by mild accommodating efforts, producing without any symptom. There is no symptom. A small amount of refractive error should be there, which is of 0.25 or zero point 0.5 only, which is corrected by using the accommodative efforts. Now, as we all know, the accommodation is done by the lens. Lens will accommodate itself with the help of ciliary muscles as well as zonular fibers. They will help the lens to contract as well as relax so that the lens will accommodate, and the asymptomatic hyperopia will correct by using the accommodative efforts. It doesn't require any kind of correction. Okay. Next one are asthenopic symptoms. Now in case of asthenopic symptoms, at the times the hyperopia is fully corrected by the accommodation. Thus, the vision is normal, but due to sustained accommodative efforts, patient develop asthenopic symptoms. Now, in case of this, it is fully corrected by the accommodation. Accommodation is done by using the ciliary muscles as well as the zonular fibers. They will contract as well as relax the lens which is present inside the eyes. In this case, the vision is normal, but the hyperopia is corrected by using the accommodation, but it develops some asthenopic symptoms. Tiredness of eyes takes place because whole time the accommodation is done, so it gives results to the tiredness of eyes. Frontal or frontotemporal headache, at the ear side the headache will takes place, at the lateral side, okay, or the frontal headache should be takes place. Next one is watering. Patient feels watering as well as photophobia. Photophobia means the patient feels uncomfortable while looking at the light. Next one is associated with the near work and increase towards evening. It is associated with the near work. When the patient have a near work in most of the time, then the headache will increase at the time of evening, or the symptoms will increase at the time of evening because it is associated with the near work. In case of near work, the patient will accommodate or look continuously at a particular distance and will not look at the another distance, so the muscles will focus at that distance only. So when the person looks at the distance, it seems to be very blurred to the patient. These are the asthenopic symptoms. Let's move to the next one, defective vision with asthenopic symptom. Now, what is the defective vision? Defective vision is the blurred vision. Okay, so this one is the defective vision. Everything is looks, but it looks blur. So blurring vision is the defective vision. Okay, in case of here defective vision with the asthenopic symptoms. Now, when the amount of hypermetropia is such that it is not fully corrected by voluntary accommodative efforts. In case of this defective vision with asthenopic symptoms are there. Ciliary muscles as well as zonular fibers are focusing on accommodating the lens, but the hypermetropia is not corrected by these efforts. So then the patient will complain of the defective vision. Okay, when it is not corrected by the accommodation, then the patient feels the vision is blurry. Okay, so these are associated with the asthenopic symptoms due to sustained accommodative efforts. Accommodation is not fully done, so due to this asthenopic symptoms are here along with the defective vision. Next one is defective vision only. Okay, so when the hypermetropia is very high, for example plus 7 plus 8, so here the hypermetropia is very high, with the patient is not be able to correct it by using the accommodation power, because the lens have limited accommodation power and it will keeps on reducing after the age of 40. Okay, so in case of this, the patient find that he is in the words or the world is seems to be blurred to the patient. Okay, so this results in the defective vision. Defective vision is this kind of vision, everything is seen but it's blur. Okay, next one, signs. Now what are the signs? Size of the eyeball may appear as small as whole. Okay, the size of the eyeball may appear as a small. Okay, this one is the size of the eyeball. Okay, it appears small. If you can see that this is the normal case. Okay, in normal case it appears like this, and the size of the eyeball becomes change in case of hypermetropy. Okay, so it is short. Next one is cornea may be slightly smaller than the normal. Okay, the cornea is this part, cornea is this part, it may be small in case of hypermetropia. Next one, anterior chamber is comparatively shallow. Retinoscopy and autorefractometry always reveals the hypermetropia. It shows plus bar only. Fundus examination reveals a small optic disc. Small optic disc is seen in the fundus examination and the margins will be blurred. Okay. Next one, a scan may reveal short anterior posterior length of the eyeball in axial hypermetropia. When there is axial hypermetropia, then the axial length of the eyeball becomes small in case of hypermetropia. Okay, let's move to the next, grading of hypermetropia. Now it is divided into three parts. First one is the low hypermetropia, second one is the moderate hypermetropia, and third one is the hypermetropia. In case of low hypermetropia, the error should be less than or equals to plus 2. It will be equals to plus 2 or less than plus 2. Less than plus 2 we will consider as 1.75, 1.5, 1.5, 0.75. In case of moderate hypermetropia, the correction will be in between the 2 to 5. 2, 2.25, 2.5, 2.75, 3, 3.25, 3.75, 4, 4.25, 4.75, and the 5. Okay, in between them. Next one, high hypermetropia is more than plus 5. Maybe more than plus 5 to greater than plus 5. Okay, 6, 7, 8, 9, 10 to 20 or more than it. Complications. Now what are the complications of hypermetropia? First one is recurrent stye. Stye occurs again and again. Okay, now what is stye? Stye occurs again and again. Next one is blepharitis, and third one is chalasia. Okay, this one is the first one, complication. Second one, accommodative convergent squint. Third one is amblyopia. Fourth one is predisposition to develop primary narrow angle glaucoma. So let's see one by one. Recurrent stye, blepharitis or chalasia. Recurrent stye, blepharitis or chalasia, it may be occurs. Okay, probably due to infection introduced by the repeating rubbing of eyes. Now the person is not be able to see clearly. What he will do? He will rub his or her eyes again and again, which is often done to get a relief from fatigue or tiredness. The patient has the tiredness in the eyes. In order to reduce the tiredness, the patient will rub the eyes. Okay. Next one, this one is the blepharitis. Okay, in case of blepharitis, crusted eyelashes, the dandruff will be deposited on the eyelashes, skin appears greasy, swollen glands, red eyes. These are the symptoms of blepharitis. Okay, next one is the chalazion. Boil can be seen on the upper or the lower eyelid. Okay, and next one is the stye. Stye always emerges from the eyelashes. The difference between the chalazion and the stye is that the stye is always painful and the chalazion is painless. The stye get converted into the chalazion. Okay, if the blepharitis will not treat it for a long time, then it will convert into the stye, and then the stye will convert it into the chalazion. Okay, stye occurs when there is a blockage of oil glands, then the stye takes place. When there is a blockage of meibomian gland, then the chalazion takes place. Okay, let's move to the next one, accommodative convergent squint. Now squint can also develop. Accommodated convergent squint may develop in the children. It develops in the children at the age of 2 to 3 years due to excessive use of accommodation. Because the children are not be able to see anything clearly, so they will start accommodating. Due to over accommodation, accommodative convergent squint may develop. Okay. Now, if you can see that this is the convergent squint. The word convergent means it moves towards the nasal side. Nasal side, the cornea gets converged. Okay, so this is the convergent accommodative squint. Sometimes the hypermetropia which leads to the squint. Squint can be treated by giving the prescription to the patient, whatever he or she wants, or sometimes surgery will be required. Next one is amblyopia. Now, amblyopia is a kind of condition that in case of amblyopia, we are not supposed to increase the vision of the patient. The eye become lazy. Okay, as we all know that we have two eyes. One eye is the better eye, and the another eye becomes lazy. So that eye will stop working and work in a limited way. Okay, the eyesight of the one eye becomes weak automatically. Amblyopia, it may develop in some cases, it may be anisometropic. For example, anisometropic means the hypermetropia may develop only in one eye. Next one is strabismus in children developing accommodative squint. Strabismus, it leads to the squint condition may be there, or one eye hypermetropic, hypermetropic will be there, or ametropic. Ametropic is the high hypermetropia and uncorrected in the both eyes. Okay, both eyes hypermetropia is ametropic, and a single eye hypermetropia is anisometropic. Okay, so amblyopia may be developed. So in this case, only one eye will work, another eye will stop work because the better eye is working. So that another eye will be considered as a lazy eye. This condition is amblyopia. We will do surgery or put any kind of effort, but we are not be able to increase the vision of that lazy eye. Next one is predisposition to develop primary narrow angle glaucoma. The eye hypermetrope is small with a comparatively shallow anterior chamber. Anterior chamber is the angle between the iris as well as the cornea. Okay, so here the angle becomes there. In case of hypermetropes, the angle becomes shallow, angle become narrow. Due to regular increase in the size of the lens with increase in the age, these eyes become prone to the attack of narrow angle glaucoma. They should be kept in mind while receiving the mydretics in elderly hypermetropes. Okay, so this one is the angle, and as increase in age, the size of the lens increase, so the angle becomes close. So this leads to the closure angle glaucoma. In case of glaucoma, the vision of an eye increasing from the starts decreasing from the side vision gets decreasing, and in case of early advanced glaucoma, only center vision will be left. So we should keep in mind always while putting the dilating drops to the patient in case of early elderly hypermetropes. Next one, treatment. Now, what is the treatment? Total amount of hypermetropia should be always be discovered by performing refractive under the complete cycloplegia. We should always dilate the patient with the different options are there, with the tropicamide plus, with the tropicamide as well as paraquine, with the homide, with the cyclopentolate as well as homide, with the only homide, or with the homide, cyclopentolate and homide, tropicamide, homide as well as tropicamide. Okay, so it should be always be treated under a complete cycloplegia under proper dilatation. Spherical correction should be given comfortably accepted to the patient, however, the astigmatism should be fully corrected. In case of hypermetropia, astigmatism means the cylindrical power should be fully corrected, and a spherical correction should be given which is comfortable to the patient. Okay, gradually increase the spherical correction at the 6 months. We will call the patient after 6 months follow up, and then will increase the spherical power of the patient. Okay, next one. In the presence of accommodative convergent squint, full cycloplegic correction should be given at the first sitting. If we will find that there is a accommodative squint as I have shown, so at that time full cycloplegic correction should be given to the patient in the first sitting. If there is associated with the amblyopia, full correction with occlusion therapy should be started. In case of occlusion therapy, we will start patching or we will closing the better eye so that the another lazy eye will start work. Okay, we are supposed to putting habit to the lazy eye so that that lazy eye will be work. Okay, this one is known as occlusion therapy. In 2 to 3 hours, so in every day 2 to 3 hours, this occlusion therapy should be done. Next one, modes of prescription. Now we will give the mode of prescription in the two ways. We will give spectacle to the patient as well as contact lens to the patient. Spectacles are more comfortable, they are safe as well as easy method for correcting the hypermetropia or the hyperopia. Next one, contact lenses are indicated in the unilateral hypermetropia. If a person have high hypermetropia in only one eye and no hypermetropia or very less hypermetropia in another eye, then we will prescribe the contact lenses to the patient. And for the cosmetic point of view or cosmetic reasons, contact lens are very good, so and can be prescribed once the prescription has stabilized. Okay, so it is very important so that the prescription will be stable for the patient, otherwise they may have to change many times. First, the number should be stable. At that cases we are supposed to give the contact lens to the patient, otherwise the contact lenses needs to be changed again and again for the patient. This was the end of the hypermetropia part 2. Thanks for your patience listening.